So I would also like to start off by acknowledging the funding sources for the study, which is the CTSC and the Star Cancer Consortium. There are 5 institutions that are involved, 2 of which I'm from: Brigham and Women's Hospital, Harvard Medical School, Weill Cornell Medical School, the University of Innsbruck, Austria, as well as Memorial Sloan Kettering. So we basically looked for association not of SNPs but of copy number of UGT2B17 and 2 other related genes with risk of prostate cancer. So as most of you already know or might already know, androgens play a central role in the growth and development of the prostate gland and also in the pathogenesis of prostate cancer. And so they have been targeted for therapy, especially the active form of it, which is the dihydrotestosterone or DHT. So for therapy, it basically targets the mechanism by which these androgens are synthesized, but equally important are mechanisms that lead to inactivation of the androgens. The enzymes that are involved in the inactivation of androgens include a set of glycosyl transferases belonging to the family of UGT genes. And these are extremely cell and tissue specific. There are 2 genes that are expressed in the prostate, namely the UGT2B17, which is expressed in the basal cells, and UGT2B15, which is expressed in the luminal cells of the prostate. And both of them lead to breakdown of the androgens. There have been 4 studies that have looked at association of deletions in these genes and association with prostate cancer. 2 of them found an association between deletions and the risk of prostate cancer, while 2 others didn't. So for this study, we used a cohort of men. The samples were collected between the ages of 45 and 75 years of age, and the samples were collected since 1993. This was a PSA screened cohort. And the cutoff for PSA was pretty stringent. It was as low as 1.25 nanogram per mil and was age adjusted. The controls that we selected had a PSA level of less than 0.25 nanogram per mil for 3 years following a negative biopsy. We selected controls in cases so that they were age matched. And as expected, PSA was seen to be greater in cases, while free PSA was greater in controls. When we looked at the correlation between PSA and free PSA with age, as expected, PSA increased with age in both cases and controls, and free PSA, we did not find any correlation, and also as expected in the cases, PSA was greater while free PSA was lower. So the genes that we interrogated lie on chromosome 4, and they are a set of androgen catabolizing enzymes that are clustered tightly. And the 4 genes that I have depicted here regulate specifically the androgens, and 2 of them I mentioned before, B15 and B17, that are expressed in prostate. We use the Affymetrix 6.0 arrays to look for copy number changes, and the array covers 3 of the 4 genes which we followed up. If you look at the histogram, it basically shows the distribution of the copy number states in the control and as well as the cases. And what you would want to see is some kind of a difference between the distribution of the copy number states. Just by eyeballing, you don't see a difference over here. And the same thing is depicted in a heat map, where obviously there are no differences between cases and controls. UGT2B7 gene was copy number 2, so it was not copy number variable. We confirmed that what we were seeing by the arrays is true by validating by PCR, which is considered the gold standard, and we saw perfect correlation. So to summarize what we found, B17 was deleted in 54% of the samples, B28 was deleted in 46% of the samples, and B7 did not show any copy number change. So we then proceeded to look for association of the deletion polymorphism with cancer. And we did not see, as evident by the p-values, we did not see any association between the deletion polymorphism of B17 and B28 with cancer. Also, since these enzymes, as I mentioned several times, are involved in the breakdown of androgens, if you have a deletion, you would expect the androgens to accumulate in the prostate and lead to activation of the downstream genes. So we looked for association with PSA, which is an androgen-regulated gene, and we did not find any association with PSA in our cohort. So basically, we had to kind of wonder why the results are so different from 4 studies and ours. And in our study, we asked, could it be the sample size? But we have a sample size capable of detecting an odds ratio of 2.1, which is the odds ratio that is reported by the other studies. So if any effect was smaller than this, we would need a larger cohort size. The second thing we addressed was the assay specificity, because most of them were PCR-based assays, and we saw that 3 of the 4 published studies were capable of identifying non-specifically the highly homologous gene, which is the B15. So we did not find the association with B17. However, we do think that this pathway is extremely important, and we may have to look at B15 and the interaction between them and see if there's any association with that. And in general, copy number of the entire genome has, at the genomic level, I should say, has been recently found to be associated with several diseases. So one has to look at the copy number changes at a whole genome level in addition to SNPs.